Good afternoon. I'm here to present my share my slides on incorporating the Pentacam AXL into my cataract workflow. I'm a speaker for Oculus. Uh, so my patient workflow in the clinic starts with the refraction. We have optometrists to do the refraction. Then they go for consultation and slit lamp with the doctor. Then afterwards, we decide if the patients go for screening for diagnostics, especially if they have cataracts. Then the last stage is the counselor doing the costing and the scheduling. So the objectives of diagnostics in cataract surgery are the following. First, we want to detect pathologies and unusual findings, and we usually need to check the cornea, optic nerve, and retina, determine what types of IOL can be used. So I used whatever the diagnostics are to screen what cannot be used. And also, we need the raw data for IOL calculation. So I'm here to just present two cases, simple cases where it guided me in decision making. So this is a 54-year-old male, blurred vision, hyperopic, and wants to get rid of glasses. So he actually came for LASIK. So my old machines I use are orb scan. So here I see a regular with the rule astigmatism. Everything seems okay, but shallow ACD, as you can see here. And then I use an IL Master 700, and it gives me all the usual parameters. Now, how did the Pentacam aid me in this patient uh, in terms of decision making? So first is we have the fast screening report, and we have three levels here. I divide the fast screening into three levels. Level 1 is the glaucoma part, level 2 and 3 are the cornea part. So in the glaucoma screening part, we can see here that this patient has narrow angles and a shallow chamber. So I can use this parameter to actually show the patient why there's a suspicion of a primary angle closure in the future for him. Corneal thickness seems normal. Steep or flat curvature seems normal. This patient is not a keratoconus suspect, in my opinion. And then we have the summary display of ectasia screening. BAD is normal, TKC is normal, and then he has a mild PNS or nuclear staging cataract. And we see here in the middle that there's a slight opacity in the middle, and I show him this photo to explain the findings. So we have this cataract pre-op display, and this is the new display of the Pentacam. We see here the SIMK in this level, keratometry readings, the total corneal refractive power is here, and aberrations are here, and all the other features. So how did this screen help me? First is the keratometry. I can see that the patient has significant astigmatism. So this patient will definitely need a toric IOL. And if the difference between total and SIMK are very less than 0.5, then I can use either. But if I suspect that it's very different, maybe I would need the total corneal refractive power to use it for my IOL calculation. The second thing is the total corneal higher order aberrations here. I use this as an irregularity index source, and if it's below 0.3 or 0.35, then maybe this patient has a regular cornea and I can use a multifocal. And the third thing is the Z400 or the corneal spherical aberration. And if this, usually we see patients in the 0.25 zone in the normal corneal spherical aberration, but this patient has a little bit of a higher Z40 or Z400. So if I need to choose a monofocal IOL, I need probably to use a negative aspheric instead of a zero aspheric or spherical IOL. And then we have a PNS score of 1, which is I show the patient that you don't have that much of a cataract. So another thing about the Pentacam is it has my favorite formula, which is the Barrett formula. I use the toric. This patient tells me it's 22.5 with cylinder of 1.5. That's what I should order. And I also do my online Barrett toric calculator, and it tells me the same parameters in terms of IOL power ordering. So I usually try to confirm using the online calculator. And in this patient, because the patient has narrow angles and a very early cataract, and I can show him the evidence, then I can recommend safely a clear lens exchange or an early cataract. We put a trifocal toric, and patient's quite happy with the result. So this is how the Pentacam AXL system helped me with decision making in this patient. This is I take photo. I usually check the axis at 1 day and 1 week because I want to know if I want to rotate the IOL. No? And I have an eye trace which gives me the toric check, and it tells me that in this case, even if I rotate the lens, I would have minimal gain in terms of cylinder power correction. So no need to rotate this IOL. The good thing about the Pentacam Wave is it's coming up with a similar functionality wherein this is the cornea and it shows you the toricity and the contribution in blur. This is the toric IOL. You see the marks here, and you see that the contribution of that, and it has a metric later on which tells you where the axis of the lens is and where the axis of the cornea is. So later on, I think this in development that they will have this for us to guide us if you want to rotate the lens or not. So another case is a 57-year-old patient, blurred vision and unhappy, wants to do something about it. I use this case because if you just use the topographer, you see that this is a very, very flat cornea, but the corneal thickness seems okay. The anterior and posterior curvature seems okay. So I was wondering, is this a post-refractive patient? Again, I took Dial Master as a routine, and it confirms that we have a very flat K, but in this patient, we also have a long axial length. That's why the IOL power seems to be in the regular zone, but very flat K, you would have expected a different IOL power. So again, the fast screening report is the first screen I look. Looks like acceptable chamber, a little bit shallow. Depth is okay. All the parameters look good. Corneal parameters look good. So this is not ectasia. This is a slight cataract. And what else is happening? Why is this cornea so flat? So the pre-op cataract pre-op screen confirms the flat cornea, and it also confirms that there's a very low astigmatism in this patient. So first stage is, look, does patient need a toric IOL? This SIMK and total corneal refractive power tells me a non-toric is enough for this patient. Second is the Z400. So because of the very flat cornea, I would have expected a very high spherical aberration if this patient had a previous corneal refractive surgery. Because becoming 37 flat means that you probably took away at least 4 diopters if the starting corneal K reading was 41. But the corneal Z400 or corneal spherical aberration is quite low, quite acceptable, 0.16. So it's mildly positive. So you can either use a zero aberration or a negative aberration IOL here. And then the last is the irregularity index, or this corneal high OA, higher order aberrations. Again, it is very low, 0.11 microns. So you can, if this is helping you decide that if the patient wants a trifocal, you can use a trifocal in this patient. So my dilemma was, there was no alleged history of surgery, low, very flat corneas, everything else looks normal, and the long axial length. So if the patient was really a myope before, it would explain that the keratometry readings now are flat because he underwent a previous refractive surgery, but he denies any surgery. So now, what formula do I use? A universal 2 or a true K for assuming a myopic LASIK? So I trusted the patient. And because of the corneal thickness, that it's still thick, then probably he did not have any corneal procedure. So I used the Barrett formula. It tells me 18K, universal too. So I chose not to assume that they have previous refractive surgery. And again, the same with the online calculator. And good thing that I I followed the patient that his history was no previous refractive surgery, and we got a good result. But
Dr.
I
Robert,
did not want.
Dr. Robert, the time is up. So
Oh,
can you
sorry.
summarize?
Okay. So in summary, the Pentacam AXL gives us added capabilities so that we can guide us for IOL selection, IOL power calculation, and extensive pre-op assessment. Thank you so much.